Thank you very much for the introduction. And first, I'd like to thank the organizers for selecting this presentation. First of all, I need to acknowledge the students that actually did the work. And this is a joint project with HOSAC Lab. So Johnny Chen, Justin Ferry, Adam Dixon, and Ali Danaliwala need to be acknowledged for this study. And I need to acknowledge, of course, support by NIH. And my disclosures are also listed here. So the story here is, again, back to the drug delivery of this morning, and again, in line with cell therapy, so to speak. Conventional agents used for ultrasound-mediated drug delivery are typically bubbles or nanoparticles, and we can convert nanodroplets with ultrasound to become bigger and release their drug, but the problem with that is we cannot have a lot of drug associated with the particles. Even we have a liposome. Liposome has much less of a drug inside, even in the best cases, than the lipids that we use that for. So the solution to this problem is, okay. I'm sorry, could I have this forwarded? It doesn't seem to respond. Oh yeah, here we go. So the solution to this is using red blood cells as a drug delivery vehicle. Much bigger particles, they come from the patient themselves. And the idea is you have essentially patient's own blood. Now in Europe there is a machine approved, got a CE mark, where you can take patient's blood, take the red blood cells and load them with the drug. The problem with that approach is it is very nice, it can circulate for days and the drug is slowly released, but you don't have ability to release it on site. So that's a problem, and the way we're solving this problem is to have a nanodroplet of superheated fluorocarbon attached to the particle and then trigger the drug release. That's exactly what was done here in this study. So first step is to find out if after putting nanodroplets on a bubble, they will still circulate. So we take some radioactive chromium, put it in the red blood cells, and after that, find out that there is very nice, after 2 hours of circulation, most of the material is still, radioactivity is still in the bloodstream, just a little bit in the spleen. And that's the time course of what is in the blood. So no problem in terms of circulation. This behaves much better than the better long circulating liposomes. So no leakage of chromium from inside of the cells. So this is how it looks like. Drug loading is done by essentially hypotonic lysis, where you put the red blood cells into hypotonic medium, and then after that you bring it back to normal physiological isotonic, and then you can get the drug sequestered. But then the next question is, can we actually release when we explode the nanodroplet that is on the surface of the red blood cell? And that's how the experiment was done under microscopy. And could I have the movie started, please? Calcium inside, after we hit it with a nanodroplet with ultrasound, that's essentially what happens. So that's the essentially the static of the same. More than 50% of the drug mimic dye is released as compared with control. And those red blood cells can sequester the calcium dye for a very long period of time, so that's not an issue as well. Next is photoacoustic imaging, so we can load ICG in those red blood cells, and that's how ICG experiment was done. Red blood cells themselves are a poor reflector at 800 nanometers, but loaded red blood cells, we can watch what they do and where they go. You can use magnetic targeting, so essentially you can load iron oxide nanodroplets inside those red blood cells, and you can pull them to the side of the tube. So likewise, we can pull them in a phantom system. So we can pull them up in this particular case when the magnet is used. Another thing that we can do is molecular targeting, where we can have RGD peptide, cyclic RGD peptide, for instance, PEG lipid derivative, inserted into the membrane of those red blood cells by simple co-incubation. And next thing you know, you have 60-fold improvement over control targeting to non-specific layer. So in conclusion, red blood cells plus acoustic droplets become acoustically active RBCs, and they're lysis by mechanisms of acoustic droplet vaporization, photoacoustic tracking of magnetically targeted red blood cells with FDA-approved ICG dye, and this is a feasible alternative for image-guided drug delivery. Thank you.
Sasha, will the spleen see these cells as abnormal cells, abnormal red cells, and therefore want to try to take them out of the circulation? Because that's one of the things that happens, is as cells age, they actually look abnormal to the spleen and they start removing them.
Well, for 2 hours it circulated enough, so we didn't see that as a big problem. One other option is to put the nanodroplet not on the surface of the red blood cells, but hide it inside, and we have loaded 100 to 100 nanometer nanodroplets by this hypotonic loading as well, so whichever works best should not be an issue.
Go ahead.
Okay. If we can make a weak liposome, can we substitute the red blood cell?
You make a big liposome.
Yeah, big liposome.
Yes and no. The red blood cell somehow escapes the spleen. The problem is, even the best pegulated liposome, if it is large, it is sequestered by the spleen very efficiently. Unfortunately, that's the data that we have gotten ourselves back in 1990-91.
We should move on.
Okay. Thank you very much.
Thank you.